Go ahead, Andrew.
Okay, welcome to today's seminar, everyone. My name is Andrew Fritz. I am a faculty scientist in the Stein Lab. We ask you to place your questions in the chat or reserve them for the end of the presentation and raise your hand, like the little icon in the Zoom. As we've left ample time for questions and discussion. Our speaker today is Dr. John Porter. Dr. Porter is the founding medical director of the Comprehensive Pain Program at the University of Vermont Medical Center and director of the Osher Center for Integrative Health at the University of Vermont. He received his MD from the University of Washington and completed his residency and chief residency at Thomas Jefferson University in Philadelphia. He is a clinical assistant professor of family medicine at the University of Vermont Larner College of Medicine, where he also holds an appointment in the Department of Psychiatry. His professional interests include demonstrating the value of integrative transdisciplinary teams and achieving the best outcomes for patients, the creation and maintenance of a healthy and vibrant workplace for clinicians and staff in healthcare settings, investigating the role of psychedelic medicines in the experience of chronic pain and the roles of mindfulness, spirituality, and self-compassion in health. Dr. Porter is joined by his colleague, Dr. Plavin. Dr. Plavin is an associate medical director of the Comprehensive Pain Program at UVM, and prior to that was CMO at Blue Cross Blue Shield of Vermont. He was instrumental in working to construct the financial care bundle. Welcome, Drs. Porter and Plavin.
Good. Well, thank you. I just want to confirm that everybody can hear me and Josh when he speaks, and want to thank you for the invitation to be here. I want to just try to advance my slide here.
This is nice.
There we go. Josh, I want to invite you just to say a little bit more about your background, if you will.
Yeah, sure. I'm an internist and a pediatrician, and I I've worked in Vermont for about 20 years, and immediate previous job was at Blue Cross Blue Shield of Vermont as the vice president and chief medical officer, and kind of developing programs throughout the state, this being one of them. I liked it so much, I jumped ship and am now here at the program, seeing patients and taking part in the research and kind of helping to develop the program and move it forward. Thank you.
Great. And I have no financial disclosures to make to the group. Josh?
I do a few clinical case reviews for Blue Cross Blue Shield of Vermont very infrequently, and that's it.
So what we'd like to do today is tell you about the program that we have been working on over the last nearly 5 years. And the goals are to reframe the experience of chronic pain, the medical condition of chronic pain, medical in quotes, as more than a symptom, of course, and really a complex chronic condition. The way we have conceptualized chronic pain in the past has affected the way we've treated it. And that has gotten into significant difficulties, as we know from the challenges and catastrophe we've had with opiates and overdoses of opiates. I want to talk about the value of a whole person approach in a chronic condition like this. So as we go through our time together today, we'll talk about what the scope of the problem is, how prevalent chronic pain is. We want to kind of reframe the experience that those individuals who are experiencing chronic pain have in their lives with it. We will go through what we've been working on with the program, its structure, its financial bundle. We'll talk about the outcomes that we have recorded so far, and then where we're headed, next steps. At the end, I'll just talk briefly about the Osher Center, which has been in existence now at the University of Vermont for about 7 months or so. So Josh, do you want to talk a bit about
prevalence? Yes, sorry. Got to get my mute off. So thanks for joining us. So I just want to touch on the scope of the problem. as this is an incredibly common issue, as I think we all can agree. So the overall prevalence in the United States of 20.5% of chronic pain, with that prevalence increasing as the population ages. And then in our population, which is really functionally disabling or high impact chronic pain, about 6.9% prevalence. So if you just look roughly at the numbers in Vermont, New Hampshire, and Maine, that's probably a reasonable estimate. And in fact, I will say just for Blue Cross Blue Shield Vermont, that covers about a third of Vermonters. It was about 10,000 patients who had high impact chronic pain. So just to kind of support those prevalence numbers. And then of course it's a gigantic cost in the economy on many levels, totaling 635 billion.
And I think that's a 2010 estimate, isn't it, Josh?
Yeah, that's 2010, so that's a little dated. And then I'll touch on this as well. So we know that chronic pain is a chronic condition like many others. And in this chronic condition, there is a very high prevalence of comorbid mental health substance use disorder or mental health issues. And we also know that these patients who suffer with a chronic medical condition and a chronic mental health condition have 40% higher medical costs consistently, both based on kind of local experience, but also some national experience as well. So it's a big driver. And our patients in our program, and this is mirrored by national literature as well, have a significant portion of them have a history of trauma of one sort or another. And then just to touch on the CDC guidelines, with their most recent updates in 22, with the focus on multiple non-invasive, non-pharmacological interventions to improve pain function and both. And so, the burden of care historically for chronic pain has fallen to primary care. And I think John and I and many people on the call can remember when we were in primary care that there's very limited therapies and even more limited insurance coverage for now evidence-based approaches to chronic pain, which we have embraced in our program. So I'll let you go to the next slide.
So just for some context, I came over to what was then the pain clinic in 2017 here at the University of Vermont Medical Center, and inherited a group of about 75 individuals with chronic pain who had been treated for up to the previous 20 years with some procedures, but with what was predominantly the standard of care, which was opiate medications. And so the group that I inherited here had an MME that averaged about 700 to 800 per day MMEs, morphine milligram equivalents, which is the way that we kind of standardized for potency of the medications. Many of those folks were on benzodiazepines. There was a large handful of individuals that was up around 2,000 MMEs per day. And at that time, even the standard for starting people, if you were going to use opiates for chronic pain, was not above 50, but certainly not above 100 MMEs. So these folks had been on medication that was dangerous and didn't have great continuity of care. And it was a really kind of a destabilized population of folks who had experienced chronic pain for many years, despite the best efforts of good clinicians, not been responding well to the standard of care, which was, again, opiate medications. So what we did in medicine, one of our missteps was to view chronic pain as a chronic symptom, right? As this is pain, this is how we treat it. When in fact, we know now very well that like many chronic conditions, this changes an individual's sense of self, of identity. Dr. Plavin already mentioned the co-occurring mental health challenges that are part of that. Trauma of many kinds is highly prevalent in the population of individuals that we see. But you get this redefinition of self, of a changed role within the family system, often significant social isolation. Work may have been curtailed or discontinued because of pain, and concurrent financial challenges can be part of the picture. As well, and Josh mentioned this as well, these are folks who do not find most medical settings to be places that are welcoming to them. That happens when you put somebody with a host of challenges that relate to how their life is going into a 15 or even a 30-minute visit every 3 months, right? And we know on the other side of that equation that the caregivers, the clinicians, feel often very stretched and perhaps even overwhelmed by the challenges that they may kind of need to work with in that setting. So we know that there is caregiver burden associated with working with folks with chronic pain. And that's really correlated with several factors, that the higher the individual's pain intensity, their tendency towards catastrophizing with their pain, the extent of anxiety and depression that they have, and the lack of self-efficacy that folks with chronic pain often feel in that interaction, in that therapeutic interaction, all correlate directly with what the caregiver feels as a burden in that encounter. So the question is how to design a program that would address as best we can as we get going this entire experience of chronic pain for folks. And so that involves a reframing, and this is a quote from our mission statement, and it's an intentional statement that yes, the pain is something you're experiencing every day, and it is also part of this life, right? And as with all forms of suffering that have significant components of duress, there are opportunities within that experience, right? So we view you as you come into the program as somebody who is intrinsically whole, who can teach us things, and there are ways to move forward for you in this process. So what are we trying to do here? Well, we do want to make sure that folks know that they're seen in their experience. Again, this is something that often doesn't happen in traditional therapeutic environments, not because of anybody's lack of effort, but because of the challenge of managing the complexity of the condition. And we want to provide you with this time of unconditional support while you're here. And people feel that from the moment they walk into the office, and that is intentional. We want to increase your sense of agency in working with chronic pain, and we want to increase your skill at handling what comes up day to day, whether it's a good day or a bad day or several bad days with a flare. We want to provide you with some skills cognitively to work with that, and access to some therapies that you know are helpful from participation in the program. And of course, we want to make people more comfortable in their experience. So the paradigm change then affects the language, or it's the other way around. I'm not sure which comes first, but people are not patients here, they're participants, implying an active engagement in the experience. We know we can't cure, but we can move towards healing, right? We can help folks rediscover those parts of them that are whole. And in the whole person language that we use, it goes from what's the matter to what matters to you, and then how can we help you move towards that goal, that self-articulated goal. And finally, and really importantly, is how do you create a work setting in the midst of a lot of suffering where the therapeutic agents stay healthy, stay robust, stay sharp in their skills. And so that's an important part of our work, an intentional part of our work every day. So let's talk a little bit about the structure of the program. This is a group experience. So it's a closed cohort, meaning that folks stay with the same colleagues as they move through the program. It's now 16 weeks. The program has been iterative since the very beginning. We started 8 weeks and we moved out to 16 weeks based on feedback from participants. So what individuals do is they come through, they join a cohort, they have a weekly session, which is either 90 minutes or 120 minutes long. During those weekly sessions, the first half of it, the first 8 weeks, is spent with the psychologist or the licensed clinical social worker, and is framed around acceptance commitment therapy, which has to do with identifying your values and then doing some observation and evaluation as to how well you're meeting those values that you hold in the process of working with your pain. The second half is framed as a medical visit, a medical group visit. And to this point, that has been myself working with Laurel Audi, who's our coordinator, and an RN and a Reiki clinician. Dr. Plavin's now doing those groups. Dr. Nauman, who is also part of us, is running those groups at this point as well. Before all of this happens, individuals and their support folks come into the office for an orientation to describe the program. And at that point, they're given a summary of kind of what the clinical team has felt were the most likely to be helpful therapies, right? So when they come in, they know that their story has been looked at by this group of 10 or 12 folks, all with different areas of expertise, and they've been seen, and here's some suggestions. And yet you still have agency in this. You can decide what you want to do as part of the therapy choice. As well, we want to make sure that the family system knows what's happening in the program. And so 3 times during those 16 weeks, family members, primary support people, could be a neighbor, whoever the individual identifies as the person most familiar with their experience, is invited in for a session that has to do with connection for those individuals, as well as understanding what's happening in the program. Kind of other offerings for folks in addition to those weekly group sessions include meetings with a health coach. There's a session on the neuroscience of pain to help folks become familiar with concepts like neuroplasticity. There's weekly conversations that are kind of ad lib with a nutritionist. There's regular cooking classes, and sessions are offered having to do with the use of cannabis in chronic pain conditions. Around those weekly gatherings, folks have access to these therapies. And so as opposed to a traditional medical office where somebody might kind of come in and schedule an appointment or two, and it might take 5 or 10 minutes, often after orientation, the receptionist here will spend up to 90 minutes with folks, scheduling out their course as they access these therapies. So different model in many, many ways. I think Dr. Plavin would agree that a key part of the success of the program to date is this transdisciplinary approach to care, right? So that it's not individuals from different therapeutic backgrounds coming in on a Tuesday or Wednesday and leaving, treating a couple people and leaving. There's a weekly integrative case review. So we look at folks and their story before they come in. The entire team comments on the story. I think I can be helpful with this because I've seen good outcomes in the past. That happens again at the midpoint of the program when we're kind of assessing how are folks doing. Are they engaging both in the group setting and in the therapies that are available to them? If not, what's happening? Kind of a curiosity, and then how to support them in getting the most that they can out of the process. And then in the hallway, where the clinicians are always talking to one another about what's happening. Somebody may be very nervous about receiving acupuncture, so they might get a Reiki session before their acupuncture session. So those kinds of synergies happen all of the time as people go through the process and as we as staff work with them. Josh, I'll let you talk a little bit more about the integrative review.
Yeah, the integrative reviews, and as John says, there's both the formal and the informal. And the formal in this setting is these 3 integrated reviews that where at the initiation, the midpoint, and the end of the program. And these are really constructed as sharing knowledge and guiding patients through their journey here in the program. And as you can see, all these smiling faces are all represent different disciplines: health coaching, OT, PT, craniosacral, Reiki, acupuncture. Base foundation of this program, which I do want to emphasize, is psychological therapies. So we have Dr. Finley, who's our psychologist, and Doug Bugby, our social worker, as part of this. And then, so there's the formal, which is we make intentional time to review and add and evolve the care for these patients. But then there's the informal. So it's very different than saying you're going to access your acupuncturist in the community and your Reiki person in the community, and hopefully they'll all talk together. But because we are physically located in the same space, that allows the informal hallway conversation to happen. Or I can run over to Janet, she's on here on the upper left, and say, hey, I saw this patient yesterday. I'd love if you could see them. What do you think? And outside of the official meeting. So that's one. I think there's two kind of secret sauce pieces to this program. There's many, but the two primary ones are the transdisciplinary component and the medical group visit component, that inviting people into community and creating social connections, which persists beyond the program. And we'll talk about that in a second. Next slide. So just a quick touch base here. So I did start with the program on the other side of the fence over at the insurer. And in fact, Blue Cross had worked for 5 years to develop this center of excellence model for chronic pain. And actually had 3 different pilots going at one time. And this was the one that sustained and was successful. Payers' vision and goals of payers, as stakeholders, have perspectives that have to do with their role in essentially providing care for and selling their services to members and employers. So they're not afraid of taking some risk, but you do have to kind of find the right people there. So the way that the payer that I worked with viewed this is that it was a test bed for a center of excellence approach. Integrative care has been brought up by so many of the clients for the insurer that they had even developed a benefit bundle for that people could buy up to. So it was not new to them. This goal of expanding care to all of the members of the insurance plan, if it was successful, and creating a plan for sustainability, because a lot of pilots just kind of die in the vine, as we all know. So it's a translation. And then, just from the payer's perspective, musculoskeletal costs and as a subset, chronic pain was a significant cost driver for their employers. And so when you go into an employer presentation and say, your number one cost driver is musculoskeletal costs, and you'd like to be able to say what you're doing about it. So,
and Josh, can I you may want to talk a little more about the bundle maybe at this point. And I'll just say that for my end of the line, as we were putting the program together, came time to figure out how to pay for the integrative therapists. If you put that through a traditional medical system human resource algorithm in terms of what the pay looks like, it's really terribly low. And so from this end, there was interest in bundling that all together. And Josh, do you want to talk a little bit about how that bundle was constructed?
I think we all know there's kind of this movement towards oft used euphemism of value-based care, but really paying for care in a different way. We were interested as a payer in outcomes-based approaches to value-based care. Realized that the fee-for-service system, even with the integrative therapies, it would be unsustainable. And after a discussion between the payer and the provider, said, maybe we should approach this as a bundle. Should we just say, okay, let's figure out a sustainable cost. Tell us what a sustainable cost would be for these services based on a duration and intensity of services that the provider would estimate. then we'll build a bundle. We'll pay you that on a monthly basis, and then you ultimately would be responsible for some improvement in outcomes. The goal was to reduce the hurdle of participation by members, and therefore the copay component was set as a primary care copay. And the way that the claim system works is even though it's 16 weeks, it's billed as 4 equal payments over those 16 weeks, so once a month. And so the patient would experience the equivalence of a primary care copay. It's never as smooth as that, just to say that, I understand. But that was the intent. And so we also created a kind of a shadow system to make sure that the utilization of services kind of mirrored, really on both sides for Fidelity, mirrored what we had estimated. So both for the cost, but also the resources in the clinic. And then at 6 months, revisited to see if that made sense, which luckily it did, and we moved forward. So just some comments about provider-payer collaboration. There's a lot, you need to do your homework, find points of shared interest, understand where the stakeholders involved. It is finding that those stakeholders, those decision makers. John and I, when we were on both sides of the fence, had presented directly to employers to get their engagement for this program. So lots of meetings, building that relationship with meaningful and timely action and follow through. Not being afraid of exploring this with payers, because I think they're open to innovation. They're open to new ways, and they're pretty motivated to find new ways to pay for care at this very time. And then in this case, it was coverage with evidence determination. So it was study what we said, we're going to take a risk and we're going to study this jointly and see if we can create value. So next slide. Busy slide, sorry, we should clean this one up, huh? So the outcomes measures essentially were twofold, just to summarize. We had survey instruments, so patient-reported outcome measures, and then on the left and on the right were the financial and utilization measures. Because of the constraints of the study, in that it was a pilot, pragmatic, observational, very limited resourced study, we were able to do pre and post for surveys on the 16 weeks, but not do what we had hoped, which was a 6 and 12 month follow-up. And we will be doing that in the future. On the finance and utilization side, though, we were able to do 12 months pre and post intervention studies to show some durability of outcomes. And then back to the survey instruments, we essentially agreed on domains that we were interested in studying, but then the provider chose what instruments they'd use for the actual study, evidence-based surveys. And as you can see, these are pretty typical DVPRS, PEG, Promise 29 for multiple domains of function. And then more specifically for the program, brief resilience, self-compassion, the CPAC-8, the chronic pain acceptance questionnaire, and to borrow from Dr. Watson of the Dartmouth Primary Care Co-op, the health confidence scale. So which I'm hoping that some of you are aware of. So it's a simple inventory patient reported that is really highly correlated with long-term outcomes. And then we can get into our outcomes. So when we look at, I'll just kind of summarize that all outcomes in this study are statistically significant and moving in the right direction in almost every spot except for one, which is okay. So we saw an overall decrease in pain, interference with life enjoyment and general activities. So this is the PEG, pre-post, next slide. This is the Promise 29. So as you can see, it's 7 domains of function, all showing improvement, either a decrease in interference with fatigue, let's say, or an increase in social roles and activities, and all statistically significant using that standardized tool. Next slide. Also saw, whilst, this is a 5-point scale, the brief resilience and self-compassion scales, but statistically significant improvements at the end of the program. Really would love to examine the durability of these outcomes long-term. Then we have chronic pain acceptance and then health confidence, which are actually the CPAC is a 5-point scale, just to point that out, and the health confidence is a 10-point scale. Next slide. So on the health insurer side, they study the cost and utilization. And so you can think of the center bar, medical plus RX, as the total cost of care. So the total cost of care dropped by 18%. And this is one year before the intervention of 16 weeks, and then 1 year after. So there was durability. We also then, if you look at clinically related groups, saying a way to group services by diagnostic ICD-10 codes, the MSK costs dropped by 30%. We did note a slight increase in interventional pain procedures. And despite the fact that the total cost of care had dropped, and our theory is that these patients who were less engaged and othered by the healthcare system, where it was appropriate, did get care that may have actually improved their pain. So I don't think we were particularly worried about that, particularly as the MSK cost dropped, with the MSK cost dropping in the total cost of care. The most important outcome, or most striking one, would be the next slide. The ER visits. So the ER visits, again, year before, year after, on a rate per 1,000, dropped by 65, 67%, general and pain related. And this is really kind of the most impressive financial or utilization outcome, to the point that Blue Cross Blue Shield of Vermont, it meets with us regularly, and they continue to meet with us regularly. And they would really want us to expand this program because it's of great benefit to them on so many levels. So, that brings us to next steps. And, one of the things that we feel that it's an important component is to create ongoing support for our members, for our patients. And that can happen here through some alumni programs, but really it needs to happen in the primary care home. And so we are exploring and piloting a medical group visit model for chronic pain within primary care, which would also, in the case of Blue Cross, allow for the continuation of a few integrative therapies on a long-term basis within primary care, kind of using the financial model of the psychiatric collaborative care model, where the payer would pay a fee, a kind of per member per month, to the primary care site, who would then redistribute those funds to the integrative therapy providers. So there's a kind of curation and relationship that's being built in the community. This has been actually successful. This payment model has been successful in the psychiatric collaborative care model, at least in Vermont, with rapid growth, I would say, throughout the state. And then, of course, we would support the primary care providers who eventually take on the medical group visits and create a network of learners in a collaborative fashion, possibly through ECHO. And then other steps might be to replicate our Center of Excellence, because there is that kind of geographic challenge. We are also moving into the inpatient space to bring this into the hospital to provide integrative pain services particularly for our surgery and trauma service. So that's in development. And then we are actively working with other payers throughout the state to expand this bundle coverage, because as I said, the fee-for-service model, as it exists today, is not a sustainable model for this type of care. We are just submitted our initial pilot study to the academic consortium journal, and that's pending publication. And then we are also exploring further funding and grant opportunities for expanding our research, since we realize this is a pilot.
And yeah, Josh, thank you. And just to say that, you know, part of what this program offers by the time folks leave after their 16 weeks is skills and a different framing of the experience. But also they know what's been helpful to them in terms of the therapies they've accessed. So the prospect of being able to carry that back to the primary care home where this medical group visit goes on, and then working with insurers, collaborating to see if we can obtain coverage for those therapies on an ongoing basis. And that's part of the work that Josh is engaged in as well through that alumni.
And just for those who are not from Vermont, in Vermont, our substance use, our opioid use disorder program is called the Hub and Spoke. And the framework is a geographically located centers of hubs or centers of excellence, then a transition to primary care with ongoing support in the primary care site. And so that framework and model was something that was very familiar to Blue Cross. And so this concept might parallel the opioid use disorder approach in the state.
Good. And I just want to pivot for 1 minute, because we are really the clinical arm of the Osher Center for Integrative Health at the University of Vermont. And that is something that the Osher Foundation approached the university back in January of 2022 and invited a proposal, which then came into to fruition last summer. And that was on the basis, their interest was on the basis of the university's longstanding work in terms of offering integrative services at the Cancer Center here at UVM and in the Children's Hospital, but also at the undergraduate level with certificates in integrative health, now minors in integrative health, as well as a minor in integrative health coaching. So there had been work going on for a number of years, but the program here at the Comprehensive Pain Program, I think was a significant generator of interest on the part of the Osher Foundation. So that comes with then membership in the Osher Collaborative, which is now 11 institutions across the country, 1 international, and a $5.7 million endowment, which we receive funds from the proceeds of the endowment every year. And again, really helpful engine for us as we continue to move and develop integrative health programs here at UVM. One of the advantages of our structure compared to the other 10 Osher programs across the country is that we're not actually centered in the College of Medicine. Our work is engaging the College of Medicine in collaboration to infuse integrative health and whole person health approaches into that. So we reside in the provost's office here at the University of Vermont, which actually gives us access to lots of entities, schools, colleges that we wouldn't have necessarily if we were centered in the College of Medicine. So just a different framework when we meet with other Osher Collaborative members who are centered in colleges of medicine, their wish is that they were able to expand beyond that realm. So we each have different challenges, but I actually like the way we're positioned here at UVM. So I think we can end there, and happy to talk further. About anything.
If anyone has any questions, they can put those in the chat or raise your hand on the Zoom. I had a question actually. The percent of people that report as having pain, is that self-reported, or is that measured by some external, like, so is that over-reported or under-reported in terms of the number of people that experience chronic pain?
It's self-reported, but it's also from multiple different sources over time, and there are this is from the National Health Survey data, and then Healthy People 2030, of course, to the CDC. So there's always that question, but on multiple different kind of and historical studies of this, it has been relatively consistent between 18 and 20%, and also internationally.
And that does bring up the challenge with pain, right? Which is that it is a subjective experience and hard to measure beyond self-measure. And for folks who are working with chronic pain who may look asymptomatic, that's part of their experience, is that, my family has no idea of what my day-to-day experience is, and it's a contributor to isolation.
So I will ask Nancy Kaplan to ask a question.
I actually don't have a question. I have a quick statement. So, John, it's lovely to see you here. So I both work for the NNE CTR, as many of you know, but I am also a person experiencing chronic pain. And I was one of I think I was the third cohort of the pilot project in 2021. And I'm thrilled to sort of see this presentation as the culmination of all that work, and also to say that the experience of being a patient in this program was really very, very profound and very, life altering in this way of having your needs heard and met. I will say it felt like a full-time job for those 16 weeks. It was really, it's your whole world. And the piece about, being silent and living with a condition like this is just, fortunately, I work with terrific people. All of them are here. And so I applaud the whole thing. I love the fact that it's part of the sort of Osher integrative piece. Really what we do in the CTR is to try to do this very similar thing. Like our whole world is pulling the threads of people together from around at least Vermont and Maine. And so, as Jan probably just put in the chat, like, let's figure out how we can work more closely together to really help from our end as well. And thank you. Yeah,
Nancy, it's delightful to see you, and thanks for speaking about your experience. It was a privilege to work with you while you were here.
I'd like to ask Mary to ask a question or give a comment.
Great, thanks. Hi, I'm Mary Brunette. I'm from Dartmouth Health. I'm in the Department of Psychiatry and Community Family Medicine. So thanks for sharing this broadly and enabling people from other institutions to participate. I had a couple of questions about the program and establishing evidence for it, and it's a logistical question about how you enrolled people. So first is how did people find out about the program, and how do they get into it, and how do you feel that impacts how people respond? And then secondly, I may have missed it, but is this program based on sort of an evidence-based practice for people who have chronic pain? And do you feel like your program needs to be further studied, or do you feel like it's really, this is just an implementation of an evidence-based approach to chronic pain? And then thirdly, I wanted to hear about whether whether your program has opportunities for trainees. We have T32 programs here with postdoctoral trainees who are interested in integrative medicine and looking for opportunities to link with providers and researchers related to integrative medicine. So those are my three comments.
Great. Josh, thank you very much, Mary. Josh, do you want to talk about entry into the program?
Yeah, so so it's changed. So when we started, we realized actually John would go around and kind of do noon conference with all the primary care clinics, because it all had to be, well, we wanted to be referred from primary care. But then we found, in addition, that it was helpful for the insurer to actually send a letter. In this case, usually it's not, but in this case, it was helpful. And so Blue Cross, under my name actually, sent out a letter to all the members who were identified as possibly having chronic pain. And there is some science behind that and an algorithm that was built and then iterated over time, which we can share with you at another time. And that actually did generate a lot of member or patient kind of generated referrals themselves. Go to their primary care, can I please be referred to? But I would say that that continues to be helpful, and we do that periodically, but there's a lot of knowledge and awareness from alumni and for primary care that have had their patients go through the program, that we have been getting steady referrals more steadily as this has become well-known among at least it's not just local, it's really, we get referrals from, I would say, from Rutland on up and sometimes beyond, and certainly New York.
And Mary, thank you, Josh. And then we also have, and you may have said this, I may have missed it, but we went directly, you said the letter about going out to individuals directly, and we did the algorithm that we thought would work, and we revised that. So that has been a process as well. I just want to talk about the evidence base of the program just for a moment, Mary. This is, as far as we can tell, a one-of-a-kind program nationally in terms of the paradigm of care and also the financial bundle which allows it to exist. And so what we base the program on, there's no other standard bearer really, but we base it on what we know about the experience of chronic pain, what is in the literature about it. It's heavily based on psychological well-being and reducing isolation and providing access to therapies that each of which there's at least some basis in the literature that they may be helpful and which people didn't have access to otherwise. So in short, we need to study the program, right? We need a care as usual versus participation in the program study, which we're working on kind of getting done. And in the meantime, the evidence that we have for the components of the program is much, much more hefty than the evidence on which we based the use of opiate medications 30 years ago in the treatment of chronic pain. So we're learning, it's iterative. We've changed the program in significant ways over the last 3 years in response to both outcomes and experience. And Nancy mentioned the boot camp nature of the program, which is why it's been lengthened to 16 weeks. And the phenomenon that we see is that about 10 or 11 weeks, people start to get nervous that the program is ending. And then another part of them says, oh, I can have my life back, right? So trying to provide enough change for behavior or time for behavior change and enough time to see if the therapies are getting traction or not is where we are right now.
And I would just quickly add that, when I spoke to NCCIH about Peter Murray about funding and described where we are with the program, there's a fair amount of, obviously there's so much to be studied here from just the transdisciplinary component, et cetera. But really, it is based on evidence-based therapies for the most part. And he felt it was much more of a implementation kind of approach and spread approach in terms of opportunities for research. So just as a comment.
Just to follow up with that, do you feel that most people who enroll in the program would have an opioid use disorder? I mean, the amount of opioids was quite stunning. And I'm just asking that because would it fall under the purview of NIDA and the Clinical Trials Network, which is a magnificent way of doing those kinds of trials?
Yeah, John,
go ahead, John.
That. Well, I think it's changed over time is the thing. And I think, I do a lot of intakes here. And I would say recently, the vast majority of intakes are not on opioids. So we've moved upstream. We've moved into where we want to go, which was prevention. Using this as one of the first interventions for people who are developing chronic pain versus after we've exhausted other things and they've been on opioids. That's not, and certainly when we began the program, we had patients come in who were not on opioids either, but I think there was a higher percentage on opioids at that time.
Yeah.
John, you can certainly give more
No,
details.
I think our wish is to get folks here when the primary care clinician first thinks about prescribing amitriptyline or gabapentin, right, to get them here. And so no, the vast majority of folks now in the program, and really even early on, there was not a high percentage of folks on opiates. That legacy group are the folks who are maintained on, who we work with, were the ones that start with such high loads of opiates. And Mary, if you'll send a note, we're happy to talk about trainees. We happy to develop that with you. And we have residents and fellows coming in here, but happy to discuss that.
Okay, great. Who should I contact?
Me, you can send me a note and I will reply.
Are you a uvm.edu person?
John, it's cvmhealth.org.
Okay.
And no H in John.
Okay,
Just
thank you so
GON.
much.
Yeah.
Okay, I'd like to ask Gary to ask a question next.
Okay, I'll be less of a pain. I only have 2 questions. Okay, so the first one is, it was very, very informative. It truly was, and obviously, quality of life is the most important outcome. But what I was wondering is whether you've tried to look at any objective criteria, biomarkers that could go ahead and reflect pain, and a whole series of other behavioral, as well as physiological changes, because that's an area that's looked at, that's being increasingly looked at. It seems to me it might really be important to correlate that with the behavioral outcomes.
Josh, do you want to?
Well, we have not obviously yet, but galvanic response. I mean, we could do all sorts of things with these fancy watches, right? So I think there's ample opportunity to expand the research base in that vein as well. I do think we relied on this kind of patient-reported outcomes basis. Because that was what was important to our primary stakeholder when we started.
Oh, for sure. But as the program matures, there's also the opportunity to look at some of the circulating biomarkers that could be very, very informative. These are epigenetic changes that really, in a number of contexts, reflect physiological responsiveness. So that might be that might be valuable.
Mm-hmm.
The other thing I wanted to say is that it would be welcome to have pilot projects for the CTR from the program, because I could see an awful lot ranging from communication strategies to measures of effectiveness, both effectiveness as well as what doesn't work. So
I agree. And Jan made a comment in the chat about that as well.
Yeah, great. Really,
those are my only 2 questions.
Helpful. Thank you very much, Gary.
Okay, I'd like to ask Biljana. I hope I'm not.
Biliana, that is fine.
Biliana, okay, to ask a question.
Yeah, so I'm one of neurologists and multiple sclerosis specialists here. And I have a question, a few questions. One is, you mentioned virtual versus in person. So was there a portion of this project done virtually? And do you have outcomes on in-person versus virtual approach? I understand acupuncture cannot be done virtually, so I don't know how that was managed.
Right, so that was a challenge. So during COVID, the program was shut down for a period of time, and then we have come back online with groups that are all virtual, some that are all in person, and then we have hybrid groups as well. So the people who are the virtual groups, they come in, for their appointments with the therapist at this point, but otherwise the group visits are virtual. And it is that balance, right, as it always is, between access. We love the access that the virtual format provides. It's a different experience to facilitate a virtual group or a hybrid group than it is an all in-person group. It subjectively feels richer, and those groups, in my experience, tend to connect and find community more easily than the virtual groups do, or the hybrid groups.
But I think it's an opportunity for future research. The pandemic made it pragmatically impossible, and we need to do what we need to do to survive. But now we are in this new hybrid environment, which invites that inquiry.
Yeah, I'm just thinking, we have our multidisciplinary clinic here for patients with multiple sclerosis. Some of them need to travel 5 hours, and it's so difficult to get them in just for one visit that lasts 2 to 3 hours, and they're exhausted. More disabled people, more difficult. So that leads to another question: were your visits all in one day?
So no, people may come here, for their group visit. They may be here, and then they may be in the building another 1 to 3 times during that week. That would be a typical, and sometimes people will schedule all of their integrative visits in one day, and frankly, we don't know what's happening in that situation. They tend to leave, like a wet noodle, but we're not sure what's doing what. So we tend to encourage separating those visits if they can.
Okay. The last question. Did you have any surveys with these participants if they had their opinion on what helped them the most? Was that appointments with psychologist or health coach or anything like that they would continue doing on a more regular basis after they complete this program?
Josh, do you want to?
Well, yeah, we do an exit survey with every member and talk about what was valuable to them, and what they'd like to continue. Actually, what they'd like to continue in the community and as an alumni. One of the things that surfaces to me, John, and you can comment further, is that people really connected with the group work, the collective, the community, the social connection, that this is a community of individuals who've been othered and isolated by society for so long, and by the health system, that this invitation to come in and be a part of this is really very, very meaningful to them and therapeutic in and of itself. By the way, we didn't mention, but we are developing a peer support role here for patients to become coaches of other patients, if you will. John, what do you think?
I think you're right. I agree. Yeah. Yeah, I think that's what we want. We want folks to come out with skills, but I think the connection piece, the community piece, which often continues beyond the program, cohorts will meet in an ongoing way beyond the program. And I think that's terribly powerful. I also think people find the skills that they learn as part of the program helpful, just in terms of working with the experience. And then coming out with 1 or 2 therapies that help when you get into a tough spot, I think is valuable and helps us moving forward with payers to be able to say, yeah, John Porter did well with acupuncture and Reiki, and coverage would be helpful on an ongoing basis. And that's where we're headed.
Thank you so much.
Okay, so there are some questions in the chat I'd like to ask if there's time. I don't want to be respectful of your time. because we're a little over.
All right. Josh, how
Okay.
are you doing?
I've got a patient waiting, but
I'm happy to stay if your person is.
yeah,
here.
if you don't mind, I really shouldn't let him wait. Thank you very much, everyone. I'd love to work with you in the future. So
Thanks, Josh.
Thank you. Okay. First question is, I'll just read it. Thank you for this talk and giving us the picture of your team. It prompts a question. What's an unexpected or non-intuitive role for your team fills, or any ideas that might suggest to a patient? Is it easy to imagine medication or meditation, changes in diet, exercise, etc.? But they're curious what your work has taught you about approaches that might have not been heard of, we might not have heard of, or techniques with some of the approaches that we have heard of.
Yeah, I think part of my experience in the program that is completely subjective and intuitive, but it does have to do with the high prevalence of trauma that people have exposed. Certainly, it's high, but it's not everybody, of course. But the connection between that emotional experience or history and how somehow that is carried in the body. And people often begin to make that connection in the program, but it prompted me to engage in this certificate program, which I'm just completing with Bob Gramling, who's the palliative care chief here for the network, in a psychedelic assisted therapy certificate course. So my interest is in whether there's a role for individuals with longstanding chronic pain, whether that modality might be useful. I'm interested in the connection between history of adverse events, how that may affect neural circuitry, as well as the greater being, and whether there are ways to help folks reset that. So that's one of my interests. And I think we don't get there in the program. We try to kind of help people make that connection. And some people see it and want to pursue it. Some people see it and say, I'm not going there, which is perfect. And for many people, it's not it's a non-entity or not an issue.
Okay. We had one comment just now. John, you want to say your comment, or?
Yeah, I was going to say, thanks, John. Really appreciate it. And I think we've talked a little bit about this in the past, like how are there ways that as primary physicians we could help extend the benefits of the program when patients get back into primary care after completion?
Yeah, and we had mentioned that earlier, but we're actually, and Josh is spearheading this effort, for folks who have been through the program, this idea of recreating a medical group visit for alumni who have been through the program, and how do we make sure that skills stay fresh and that they remain connected, and then ideally have access to therapy. So this notion of moving medical group visits out into the primary care settings, I think, has real merit. And our experience with it here is that those group visits are energizing for participants, but also for the clinicians, that it's a different experience to sit with a group of 8 or 10 people, who are in times of suffering, and have them interact and have the group have a great deal of wisdom that it shares within itself. That's buoyant for the clinicians. And I think, as opposed to meeting with those 8 or 10 individuals who are all suffering individually, it's a very different experience. So I am a proponent of medical group visits. I think it's also a template for other chronic conditions that will be helpful, hypertension, diabetes. So I think there's a lot of creative things we can think about doing with that approach.
Thank you.
Thanks, John.
Nancy, if you wanted to talk about your comment, or let's just read it. So I think I also think that the EMDR therapy helps to address the underlying trauma issues without using psychedelics, is what the comment was there.
Yeah.
And then the last question that I wanted to have the opportunity to ask is, are there ongoing research opportunities for patients in rural communities in the Northern New England area?
Yeah. Well, I think, you know, part of our concern, we were grateful to Blue Cross Blue Shield for helping us set up the bundle. We're working really hard with Medicaid now to get coverage of a similar bundle. And I think we've seen some nice progress. I think that, I'm not even going to say it, but we're working on it. So we're hopeful there. And the Deputy Chief Medical Officer for Medicare is coming out to look at the program sometime this summer. So we want to expand access to the program even as we continue to study it. But we do not like running a two-tier program where some folks have access to the full smorgasbord of the program. And then we also have the Compass program, which is the more traditional fee-for-service for other folks. So we're committed to not recreating the disparities that we see everywhere in our healthcare system. But it's a work in process.
All right. With that, I'd like to thank everyone for joining and have a great day. Thank you, John.
Thank you all very much.
Thank you.
Take care.